Right, Derek. Thank you. Thank you so much for joining today to this talk between two orthodontists. It's very important to me to mention that because obviously I teach now a lot every week. I'm traveling the world to spread the message of the importance of prevention, including airway. So you've been on the journey for much longer than me, actually. And we are still sitting here talking about it, and it has not become the norm yet that we do airway screening in children and adults. Why?
Crazy. I can't really give you a rational reason other than, I trained in the UK. When I trained, it was quite a prestigious faculty, the Eastman Dental Hospital, the University of London. There was not one lecture on mixed dentition treatment, let alone airway, right? I guess, like you, I kind of put the pieces together by looking at the patients I was treating. And I saw some amazing outcomes from colleagues of mine who were doing early treatment, who were looking at airway. And I compared the results they were getting and the faces they were getting to my results. And I could see clearly there was a disconnect. And I think, like you, I've been heavily influenced by people in the sleep medicine world, more so than the orthodontic world, right? I think even in Australia today, the average orthodontist, if he's doing what we call phase one, is really lining up the four incisor teeth. That's it. There's no deep dive into the kid's sleep, into their bruxism, why they're wetting the bed, why are they not being attentive at school, why they show hyperactivity. Yeah, there's nothing like that. And the sad thing about Australia, I don't know if you know this, but we have the highest use of Ritalin per capita than any other country in the world. We have the highest incidence of teenage suicide than any other country in the world, and all of these things, I feel the missing link is sleep, poor sleep. And, I recently finished my PhD. I took nearly 20 years to piece together craniofacial abnormalities and how they affect the child's sleep. And without a doubt, and I'm very happy that this has been accepted for publication in International Journal for Craniofacial Research. And to me, this is my journey, right? Because I went
But
from,
Derek, let me stop you there. Like you just
yeah,
mentioned, it's been accepted in a cranial facial journey. How about being accepted in an orthodontic journal that our colleagues actually know about these things? Because it seems like they're completely closing the eyes when it comes to airway and the dental world, which is anyway catching up with technology and aligners pushing on the market, taking away a big market share of us orthodontists, to be fair, are
yeah, yeah.
completely on board with that. But orthodontists are blind to it. So why did you not publish it in an orthodontic journal?
I think too much politics, to be honest with you, right?
Wow.
I know from the AAO white paper on this topic how people interpret it the way they wanted, and people just wanted to continue what they were doing. I mean, I heard your podcast with my friend Dr. DeLuke, and I really liked that whole debate you guys had on the Tun K Schiffman article on how expansion doesn't work, and it's just to me, who does a lot of early treatment, a lot of expansion for airway, and I see the difference in these children. It's kind of amazing that this stuff still goes on, particularly in the UK. I mean, Australia is, I think, getting a little bit more progressive, but I wouldn't say as progressive as some other countries that I've visited and seen. And I mean, there are some countries, Brazil, big emphasis on orthopedics, big emphasis on looking at lip and tongue tie in children. Very, very good quality research coming from there. But again, I mean, I know you were like one of the number one Invisalign users in the world, right? And uh, you saw that you can align teeth with Invisalign, But if you miss that boat when the child's growing of changing their jaw structure, I mean, it's really, I feel, not the best for the patient.
I mean, coming to that this is also where a lot of people go wrong. Like if you don't know where to move the teeth or how to create a big foundation for these teeth, it doesn't matter how good you are in Invisalign or any other technique because you're still moving them in the wrong spot. So the emphasis, unfortunately, nowadays is on AI, pressing an AI button so that the AI will do the treatment planning for you and the diagnostics for you instead of developing a protocol for diagnostics, writing a good diagnostic plan, a good treatment plan, and then choose any tool you want to get there. So I
Yeah.
think this is a shift of completely in education that orthodontics seems to become super easy. AI is doing it for you, hence it becomes more accessible to dentists, and they're
Mhm.
obviously taking it. So it's very, very frustrating, especially when you see the increase of chronic diseases in children, ADHD, obesity, autism, and you see that trend we are experiencing. It becomes quite frightening to witness the trend of these diseases, and nobody seems to understand there's a link.
Yeah, yeah, absolutely, absolutely. And I think we as orthodontists are probably the best placed to help in this diagnosis. A, we have a relationship with patients for a lot longer than most medical specialists. B, we look in the mouth, which is so many early signs of the problems. C, we are training as specialists is very good on growth and development, right? I mean, I've taken the journey from straightening teeth to then learning dental fascial orthopedics, and I now have had postgraduate training in sleep medicine. And to me, that was the missing link. I could then sort of link everything back to, bruxism. You ask an average dentist in your country or my country, you've got a young child who grinds their teeth. Is that a red flag? You've got a child that snores. They really pass it off as, oh, well, they'll grow out of that. Or, I think these are early signs of the things that we see. Let me put it this way. The only thing I ever did for sleep medicine as a traditional orthodontist was work with my Max Fac and do an MMA, two jaw advancement surgery plus or minus junioplasty. It was life changing for the patients, life changing. Um, Yet I asked myself, if you can move the jaws forward while the jaw's growing and avoid the surgery and get a better airway and get better oxygen to the brain earlier in life, why would you not do that? Why would you wait until it becomes a major problem? And I think a lot of orthodontists are doing some sleep medicine, but they're doing it at the end stage when it's become OSA. And I think we could prevent that from happening, from simply listening to our parents, their concerns. I know you ask your parents to shoot a video of their child sleeping with some order. That's so amazing. And having that information at the initial consult is to me, such a valuable, and it doesn't cost anything. I like all my parents to fill out one of the pediatric sleep questionnaires. I also like them to take some photos of the kid sleeping, the posture. We tell them about the free apps like Snore Lab. They can, all this stuff gives me a picture before the kid walks in. So I'm not focusing on that kid's canine having no room. I'm focusing on the bigger picture. What is this kid's overall health like? Do you know what I mean? And it's so rewarding.
And
Yeah.
you pointed something out with the surgery because when you do surgery on adults, you see not only the profile change, you see how the skin is changing, you see
Yeah.
how the tip
Yeah.
of the nose is changing, you see the eyes are changing because they get
Yeah.
more life in them. So now let's talk about university again. We have been trained to influence the mandible growth in teenage years because of the peak of puberty. That's the best
Mhm.
time to treat a mandible. So,
Mhm.
do you agree with that? Or would you say, actually, we're missing a few opportunities before that where we can bring the lower jaw forward in young children, 5 to 10, where they have increased overjet or they are trapped with a deep bite, they're grinding. where we could also bring this lower jaw forward. And this is in the UK, especially when they start treating at 12 or 13, 14, they're missing these huge opportunities early in life to bring this jaw forward, to release the trap, I call it. But
Yeah.
what's missing in education, Derek? I mean, you train forever. And why is everyone focusing on this late stage when we have suddenly a much more difficult patient as well? What's
Yeah.
going wrong?
I think those who really look at just the literature look at the work of McNamara, Frankie Barchetti on the cervical vertebrae. And they're the ones that come up with the, during the pubertal growth spurt, even post-puberty in males is when you're going to get the most growth of the mandible. Okay. But I say to parents, if your child can't read properly because they need glasses, when would you wait to put the glasses? It's nonsensical. And what I'm finding, and this is what McNamara used to say, the maxilla, if it's narrow, if it incisors a division two, you're trapping the mandible. So I always look at natural growth and compare it to what we see in kids. So natural growth, if you look at the research, you look at anthropological studies, children in primary dentition have big gaps between all their teeth. You don't see that in the modern individual. What I see is overclosed vertical dimension, right? And the mandible is definitely being trapped. And if you look at endochondral ossification, that's how the mandible grows. Endochondral ossification is stimulated by breastfeeding. That child has to put their tongue hard on the nipple, constrict it to release the milk, and then they have to keep bringing their jaw forward to get the milk, right? So, I think so many children don't, the parents, because of work, because of whatever, don't breastfeed to the time they should. Then they put their child on pacifiers, or they express and use a bottle feeder, and all of that is encouraging the tongue to go in the wrong position. So definitely I'm seeing more and more malocclusions. Now, I went from treating all my patients at 13 on average to then going to mixed dentition. That was a big leap of faith for me, 7 to 9, right? Now, when I really understand about airway and I understand about craniofacial growth and I understand that the majority of the brain growth occurs well before the child goes to school, why would I wait when a child is not breathing properly, is losing up to 10 IQ points per year? If you look at the research by Dr. David Gozal in the brain mapping, etc., why would you wait on those children? But I do tell the parents, I'm not doing orthodontics because some parents in Australia, they kind of want to pay just once and they think, wow, I hear what you're saying, but will that mean my child will avoid braces? I say, I don't know about that. That's a long way from now. But what I can say is I can improve your child's health right now. All these
I think
things
this
that,
is a
and I
very
go through
important
things.
point, Derek, because
Yeah.
for us, we're not treating the teeth actually. We're
Mhm.
treating the human being behind the teeth and their health. And it's a very
Yes.
different approach to all of our colleagues, even all of our dental colleagues. For us, it's not the teeth. The teeth just show us a symptom of the problem that is
Yeah.
underlying it. And this is a very
Absolutely.
big difference. And you have now 7, 9 clinics in Australia. Yeah. So you're
We
growing a lot.
Yeah, yeah. Because I have a good group of orthodontists who, I choose people who to work for me, not based on how well they did in orthodontic school or how well they can bend a wire. They need to be on the same philosophy. We need to all be on the same page, right? And we've grown so much in Australia. We're the biggest orthodontic provider now. We have 13 clinics around all of the eastern seaboard, from Tasmania to Victoria, New South Wales, Queensland. And the reason we're still growing, like last year, we grew 22%, where everyone else is crying with, I tell you why other people are not growing that well. They're all competing for the same market. It's all aligners. Like you said, in Australia, more clear aligner therapy is done by a general dentist who unfortunately does a 2-day course and he can provide aligners. And the patient knows no better. And we have this race to the bottom, I call it, right? Race
I
to the
do
bottom, where
exactly the same.
yeah, everyone's straightening teeth. No one's looking at the bigger picture. Now we come on the market and I'm passionate about what I do. for a number of reasons. I was the victim of very horrible orthodontics. I didn't know that. I was a kid. My parents took me to the best orthodontist. I had bicuspid extractions and headgear, and I was a simple class 2 div 2. A simple case that probably needed the incisors flared, a bit of upper development, and I'm brachyfacial. I I would have just grown normally, but no. I had the retractive orthodontics. I have sleep apnea. I have TMD. I have everything that I can relate to. So I give my message to parents and I say, listen, back in the day, I had this, you had that. There's a better way. And now there's a lot more in the literature to confirm that this early treatment is helping the airway. I love Audrey Yoon, and I think you have also spent a lot of time with Zarus Zaghi. All those guys I met in my journey when I was at Stanford, Stanley Liu, Christian Gumino, they all had the same passion. Now, Christian Gumino, he developed AHI, the scale. But he said,
Unfortunately.
but he said he regretted doing that. And he regretted the fact that people have just made up the numbers for children. Now, with children, they're so muscles are so active, they're not going to collapse long enough to even record an apneic event. So many people get a kid sleep study on the wrong criteria and are told your kid's fine. And the kid's not fine. The kid's got recurrent otitis media. The kid bruxes. The kid's not sleeping well. The kid's wetting the bed. There's all this going on, and yet they don't stop breathing long enough to make it a medical necessity. And Christian Gumno, he said, I wish that all those years of research I did, which was treating the end state disease, I should have focused on prevention. And what was he in his last few years in research and when he was talking, it was myofunctional therapy, it was early expansion, it was bringing the jaws forward. Fantastic. And this is really one of the fathers of sleep medicine, right? I learned sleep medicine in Australia through a guy called Colin Sullivan, and he developed the CPAP machine. He had the worldwide patent for CPAP, right? And he himself says, I developed CPAP for the end state disease, but really the goal is to get people off their CPAP early, right? I know you're very passionate on children not being just put on CPAP for the rest of their life because we understand growth. And there was great papers also by Christian Gumino that the maxilla, the forward growth of the maxilla is affected negatively if you put the child on CPAP. So you're fixing one problem, you're creating another. So this is where we, as what I would say, craniofacial biologists, we understand how to widen the jaw. And all the critics in the UK that boo-ha this treatment, if you ask them, have you ever expanded a foyer? Have you ever done it? I mean, physically, have you ever done it? And the answer would be no. They never even see a kid that age, right? And I have other colleagues who say to me, Derek, we know what you do and we believe in it, but we run a busy practice and I'm happy. And having a 4-year-old in the middle of, after school when I have, all 12 chairs full and I have 5-minute wire changes, it's disruptive to have that 4-year-old in the chair. So I think there's some of our colleagues who know what to do, know the right age, but just are not ready in their practice to do that. And I think I'm hoping that will slowly change, where we put patients' health ahead of their teeth, because you can straighten teeth at any age, but you get a one window during craniofacial growth to get that right. And I think that's a message certainly I've heard you speak about, and something that I firmly believe in. Now,
But Derek,
next year,
these
yeah,
orthodontists, I mean, we are a very small community actually compared to dental community. And
yeah,
when I opened my teaching academy 2 years ago now, the intention was to train orthodontists in the UK to do early interceptive treatments. And I realized that they're not actually coming. The people coming
right.
are the pediatrics. So why are they so opposing to what you just explained? In its common sense, really, what you say, it's my common sense. Why do you feel they're so resisting to this opinion, what we have? I don't understand how they can stay there and said, I continue the way I do because I don't have time for 4-year kids, or I hear I don't get enough UAs, like points, orthodontic points for early intervention. I get more money when I do extractions. What needs to change for them to get it?
I I mean, I tell you who's maybe they will never change, right? But I tell you who's driving the change. It's parents, mums, right? Social media. You know, I graduated 40 years ago. There was no Google, there was no internet. Now, my God, like you can, you talk to any of our parents who are happy after we improve their child's health and airway. They talk to other people, and then they look on the social media, and it's the parents driving the change, right? I can't answer the question honestly. I know Mike DeLuke asked me the same. He said, "Why is our profession so resistant to this change?" I don't know. I know in the UK everyone follows the teachings of Kevin O'Brien and his numerous literature reviews. But really, I'm in the real world, and I am helping patients sleep better. I know a lot more about sleep than the average orthodontist. I've done years of training to get myself to that level. When I talk to my medical colleagues, my ear, nose, and throat doctors, my pediatric sleep physicians, they get it because they're looking at the medical model and they understand the importance of this, right? So I think the disconnect, we are taught how to straighten teeth, and we're the most equipped at straightening teeth when the patient has all their teeth. That's what it comes down to. So if your comfort zone is, straightening teeth, and again, don't get me started on that whole debate about extraction, non-extraction. They're still trying to come up with the latest was it angled was it orthodontics? They looked at CBCTs in extraction patients to come to the conclusion that extraction doesn't have any negative impact on the airway, right? This is the same group that all of a sudden were bad mouthing CBCTs, and why are orthodontists taking them to look at airway? Now they're using it for their own argument. You can find anything in the literature to 180 degrees disagree with another thing. We know that the literature, particularly the orthodontic literature, is so fundamentally flawed when it comes to good quality research, right?
And
But
also, none of
yeah,
the literatures is actually looking at the overall pictures, how our body is adapting to these
yeah,
extractions. You mentioned your case, premolar extraction. I was class 2 div 1, headgear therapy for years and years.
yeah,
I had
yeah,
also moderate sleep apnea. We are both victims of our own treatments. And
yeah,
nobody in
yeah,
these research papers looks at how did the body adapt to these extractions? What's our head posture look like? What difference does it make in our airway volume that we actually measure? And this is
mhm,
what people don't talk to you about. Also, when you go on orthodontic conferences, they are these airway orthodontists who claim to open airway, but what they did is change the posture. So
yeah,
it's just, and it still baffles me that people don't talk about it. I get very frequently on a line of Congress, I see people distalizing the teeth. Yeah,
yeah, yeah,
there was open bites, they're intruding teeth, and nobody mentions in a single word the function. None,
mhm,
not a word. So
mhm,
all of these young colleagues sitting in the audience applauding the speakers. Wow, you
yeah,
can intrude teeth with aligners, amazing. But nobody talks about the tongue and the tongue tie that caused the
yeah,
problem.
yeah,
So
yeah, yeah,
I mean, it's just incredibly frustrating what's going on. That's why I think we should go to universities and start at the bottom of it in our education. Because if orthodontists are not careful, in 10, 15 years, they're the same as any dentists because they're
yeah,
fighting for the same market. They
exactly.
can't
Yeah,
differentiate anymore. The only differentiation is price. You have 15 clinics. You know by what you're doing, you actually can be successful as well. So if you would fight for the same market, you wouldn't have these clinics.
Yeah, absolutely. You've got that. You absolutely got that right. And what I'm offering, parents want, many referring dentists want. I have referrals from a dentist I've never heard of before, but I've developed a brand reputation for treating early and minimizing extractions, right? So when the parent goes to an orthodontist who recommends watch and wait approach, or will definitely need teeth out in future, even though the dentist doesn't know me personally, they will tell the parent, you know what, go and see that guy. If there's one guy who's not going to take teeth out, I know it'll be him. So by default, I'm getting that word of mouth referral, and then I try and educate that dentist because many dentists don't understand the difference between an orthodontist who straightens teeth and someone like you and I who's focused on the airway, right? If I asked a dentist in Australia, what is an airway focused orthodontist? They'll probably have no answer, they might
Uh,
say, oh, it's someone who expands, but
it's
it's so
so
much bigger. It's so,
our
see,
story.
I always say, if you've got an airway problem, that's an AP problem. And this is what my research showed. The majority of airway problems were not transverse. They were maxillas that were retrusive, what we call mid-face deficient class threes. And they were really mandibles retrusive, the class two retrognathia. And the worst were the children that both maxilla and mandible were retrognathic. So it just makes sense, right? If your jaws are too far back, of course, that's going to compromise your airway. And if you're moving the jaw, you don't have to wait for teeth. You move the jaw when you're getting good growth, and then you rehabilitate the airway. So many orthodontists don't even know what a myofunctional therapist is. I'm lost without them because I could make the room for the tongue. My ear, nose, and throat colleague helps me clear the airway. But ultimately, someone has to retrain and reteach that child to breathe with their lips together through their nose with their tongue sitting on the palate. And that, if you do that early, you watch that face mature. It's what we call in Australia a no-brainer, right?
By
And
default,
yeah,
yeah. You know, it's so
yeah,
when I listen to you, I listen to my own story. It's so you have a few years ahead because when I opened my business now 3, 4 years ago, I approach every dentist and says, I want to treat children. I don't want to interfere in your business with teenagers and others. Just give me the kids. And we had sent 70 invites, no response for free dinner,
okay,
free food, education. So now, 3, 4 years later, I get the referrals from these pet dentists because they're sending their own children, then their experience with their
yeah,
own children,
yeah,
you know.
absolutely,
And you
yeah,
hear from dentists you never heard before, suddenly sending the
yeah,
kids. So orthodontists who listen to this, what we are telling them is, you are in Australia, I'm in UK. We're sharing exactly our same story. You
mm,
have been successful. You'll continue to grow. I grow 44% this year.
wow, wow,
Yeah.
and I think I don't know what the national average of growth of an orthodontic practice, but many. I mean, if you grow 10%, you haven't grown. You've just maintained stability, right? Uh, but I just wonder with the advent of everyone offering clear aligners, everyone, right? Even in Australia, like oral health therapists can open their own clinic and they can offer clear aligner therapy, right? We saw the demise of those big companies that were doing, what do you call it, in through the mail aligners, where you didn't need the orthodontist at all. And at the end of the day, teeth were still moving, maybe not as well as they could have been with IPR and attachments, but it put a message into the mind of the public that anyone can use aligners. And I'm being ripped off if I'm paying $10,000 for aligners when I know that I can pay 3,000 through the laboratory. And at the end of the day, there's no skill. See, the public view someone offering aligners as a provider like anyone else. And if they're using Invisalign, they shop around and they say, well, how much do you charge for a set of Invisalign? Whereas when I have a conversation with a parent about their child um, health, not sleeping well, not paying attention in class, it's a whole, money doesn't come up. It's not a discussion about how many aligners, can you beat this price? Because I've already seen three other people providing. It's not, it doesn't happen. It's very refreshing for me,
And
right?
also, they will beg you, are you seeing adults as well? That's what happens to me. I focus on children and then they
Yeah,
beg you, would you see me? Would you consider seeing me?
yeah,
And not even mentioning the price. Price is not a topic. And
yeah,
this
yeah.
is so fascinating. You are literally at a different side of the world. You have the same experience as me. So if orthodontists are watching this, they should think about what's happening in their market because they're losing patients. They're losing
Mhm.
their contracts in the UK of NHS. So their flow of new patients is basically gone. They need to really think carefully which way they want to go. Also, our young colleagues who have been trained at universities, we really need to think about where do I want to be in 10, 20, 30, 40 years' time? Because if they follow the path of a normal orthodontist, there won't be one.
Exactly, exactly. Yep, yep. And you know, I've had some young orthodontists who just graduated come and apply to me for a job, right? And and some of them ask me, uh, what did I think about them opening their own practice? And I say, you'd be crazy in the current environment to put up your shingle saying, I'm a specialist, and you're not doing anything unique because all the dentists are doing their own orthodontics. Trust me, if it's aligners. But if it comes to what we do, hardly any people do that because they rely on specialists who work in a team with sleep physicians, nose and throat doctors, but they're very good at picking the problem. Once you, I mean, I love using Zarush Zaghi's Six Flags. My colleague Bill Harrell, he's developed another system. It's just a checklist, where you measure intermolar distance, you ask questions on snoring, and it just gives you an idea, like say some questionnaires have 9 questions, some have 20. But at the end of the day, the more yes answers you get, the more you can identify that child has a problem, right? And you can't then say, I'm going to wait until you're in an adult dentition before I start my treatment. Because if the kid has all these problems, how can you justify waiting?
And also, that's really important. So, by you are doing your questionnaire, I do exactly the same. Yeah,
Yeah,
I have 11 to 12. Does matter. Suddenly, you have Airway on your problem list, and their Airway problem list is super high. The minute you have severe risk for airway problems, it comes very much on top of your priority list for treatment. Hence, your
yeah,
whole treatment thinking is completely different because you need
yes.
to focus on the child breathing, which is outweighing teeth or anything else because this child is not breathing. So it's so interesting. So now it's a good introduction to tools because I'm involved in groups in UK where dentists predominantly doing ALF, they're doing BioBlock, Homeoblock, all of these people who are influenced by John Mew, Mike Mew. Um, you as an orthodontist, I want your opinion. The tool, what tools do you say are working, and what is your opinion about the different tools available to do what we are talking about?
When you say tools, you mean the appliances
Just
or? Yeah,
appliances.
yeah,
To
yeah. Look,
basically identify the problem. But now it comes
yeah,
about the premaxilla, the expansion. Some people they
yeah,
say, oh no, only BioBlock type 1 is working, Alpha is working,
yeah.
Homeoblock is working. They didn't even accept a rapid maxillary expansion, even it's not really rapid, and they don't accept aligners as a tool. What's your orthodontic opinion on these tools, devices being used for this topic?
One thing I don't agree with, and I get a lot of people who come from the orthotropic, what do you call it, social media, and they firmly believe that they're single males, maybe just under 30 years old, right? And they firmly believe that they can grow their jaw forward with just tongue positioning or removable orthopedic appliances. Now, when you understand craniofacial growth, the time you can modify growth is definitely during the growth phase of that jaw, right? So I say to the patients that I guess it doesn't matter what tools you use. So if someone likes BioBlock stage one, and I use an expander with a face mask, ultimately we're achieving the end net goal. And that is we're widening the upper jaw, we're bringing it forward, we're getting the teeth out of the way so the mandible can grow forward. So I don't really get held up in appliances. I know particularly with the orthotropic philosophy, it's very specific on stage one, stage two, stage three. And let me tell you, I've done a lot of BioBlock cases in growing individuals, in children, amazing results. But in my practice, because I'm busy, and maybe it's the Australian child is very different to the UK child, but compliance is a big problem for me when I make the appliance removable, a big, big problem, right? Um, so I think if I can fix it in, but I can design it so that it minimizes the tongue. Our goal is to get the tongue on the palate. Why? Because if you get the tongue on the palate with the right force, you're going to encourage intramembranous ossification. Those sutures become active. The jaw grows the way nature wanted it to do, right? We've seen all the environmental epigenetic type studies on twins. We've looked at, a set of children where one can't breathe through the nose, and the other one has a perfect airway. I did my original research. What got me on this whole bandwagon way, way back in Sweden with Linda Aronson. I spent time at Huddinge in Stockholm, Karolinska Institute, and I was amazed at what he was doing. And he really measured everything. He made us measure like 171 variables on all these patients, and he paired them so well, where he had children who were mouth breathers, who stayed mouth breathers for whatever reason, children who had just adenoids out and were taught to breathe through their nose, and he measured their jaw size, their crowding, the growth of their face. It's a landmark study, right? And that really convinced me that yes, airway is integral in establishing a good forward growth of the jaw, if you want to call it that term. But what appliance you use, I think, is totally up to you. It's like religion, isn't it? Like if you're a good person and you help your neighbor, right? It doesn't matter what religion you are. In the same way, if you use BioBlock versus another, that doesn't make you a bad person or a good person. But if your net goal is to help that child breathe better because their jaws are going forward and their face looks better and their tongue has room, then of course, welcome to our world. Yeah,
I think that was because I feel exactly the same. Like when you prioritize airway in your
mhm,
treatment and you have kids, they stop actually breathing. You see in their videos we taking, they have
yeah,
apnea events.
yeah,
Then you cannot give the responsibility to a child with a removable device to do their own airway. It's us
yeah,
professionals who needs to put something in there to help them breathe quickly. After we
yeah,
corrected the breathing issue, we can do whatever
yeah,
we want. Removable, fix, well, it doesn't matter, but you corrected the breathing. And this is exactly how I feel. I don't leave it up to a child. Like now, Invisalign launched their new Invisalign palatal expansion. This is the biggest critic I have on the device. It's removable. So if you
yeah,
want to change the airway of a child, you give him the responsibility to do it themselves. You have a high risk that you might fail because of compliance. And when you know
mhm,
the urgency of airway, you can't do it as a clinician. You can't give
yeah,
that responsibility to a young child. So hence
yeah,
we have to do the job with the parents together. They need to be on board in the journey we're trying to do. And then within a few weeks, Derek, 2, 3, 4, 5, 6 weeks is a long way. with Airway
Yeah.
when you do a rapid maxillary expansion. And
Yeah. Yeah.
rapid doesn't mean rapid in our world anymore because we're not turning two, three, four times a day anymore in young children. This
Yeah.
is
Yeah.
past.
Yeah.
So it's a wrong name actually that we used. And I just had a discussion 2 days ago. The BioBlock, they're turning an eighth of a turn a day. So it
Mhm.
means in a week over a millimeter. But
Mhm.
what
Mhm.
I do with the rapid maxillary expansion is actually 2 turns a week, which means 0.4 millimeter expansion a week. So I do actually less
Yeah.
intrusive in expansion than they do with the other device. So I 100% agree with you. It's only a device. If we know how to move the teeth in the right direction, we are actually helping. It doesn't matter how you help a kid,
Yeah.
we are all helping them. And most orthodontists and professionals we are talking about are not. They
Yeah.
actually don't see the problem. They see we wait for a problem and see our kids degrading in the ability to cope in life. Their barrel of water is being filled up from the get-go, and they're ending up with anxiety, depression, the pressure of life, and we
Oh, yes.
can't
Yes.
continue that way. I mean,
Yeah.
it's insane that our small community sometimes is fixated on the tools, attacking each other. Oh, you use an ALF, you use a BioBlock, you use an ARMI, you're all wrong. It's my way or no way. We shouldn't
Yes.
be as dental colleagues like that because we end of
Yes.
the day we
Yes.
all want to help, and the kids
Yeah.
need help.
And I think I like your point. When I look at a Hyrax, I don't know if it's RME because RME is the rate you turn it, right?
Right.
Yet I have people who will look at a Hyrax in one of my patients' mouth and says, "Oh, he's doing RME." He's not doing RME. He's using a Hyrax appliance, but the rate of turning is not rapid, so it's not an RME. They don't get that because they view any fixed expander as RME.
I
This
know.
is the problem, right?
I know it comes
Uh,
back down
uh,
to education. It's
yeah, yeah.
And this is the frustrating. We should be teaching in universities all over the world together
Mm. Mhm,
to
mhm.
make this change because I feel very strongly about it. I see so many dentists approaching me for courses, pediatric dentists. If you look at pediatric guidelines in
Yeah,
America and China, they have early interceptive now in their guideline to check for airway versus the orthodontic community doesn't implement it. It's
yeah,
crazy. Pediatrics
yeah,
are being asked to screen for airway and
yeah.
orthodontists are not.
And one of my closest friends, co-researcher as part of my PhD, Audrey Yoon. She is a breath of fresh air. She was a pediatric dentist that went back to ortho school, but now is and then has a postgrad training in sleep medicine. And she puts it all together. The article that everyone should read is her roadmap on craniofacial growth. It's beautiful because
Absolutely.
it starts from zero, right? What can you do? What you look for, right to when you've missed the boat, and then you have to start putting skeletal anchorage, but you can still do something, right? And yet she gets such criticism from her colleagues. I remember she was invited to speak at the AAO. It was probably the best lecture I'd heard for the entire meeting. And I go to the AAO every year for the last 35 years, you know? But she was shot down like unbelievable, unbelievable. Like she was yeah, I don't know how to describe it, and why she's offering an alternative way of thinking. And if you're not ready for that thinking, then fine, but don't knock her for being progressive. And I hope, I'm sure you do, 10 years, 20 years, 30 years from now, there'll be no debate. There'll be something new that we will be all wanting to achieve, but everyone would agree that fixing the child's airway is the prime role of the orthodontist, really, right? Really.
And
And
Herman
when people ask me,
Ramirez.
yeah,
I met Herman Ramirez 2 weeks ago in New York. Same thing,
oh yeah, yeah,
pediatric dentist, studied orthodontist, studied. It's the same
yeah,
journey as Audrey. So
yeah,
these people we are talking about, they went through their own journey, and everyone I deal with have their own history, their own journey, why they are so engaged in this topic. They have
yeah,
their own
yeah,
cases in their kids. They were suffering themselves. Whatever you ask them in the podcast, they all have their own journey, which made them say, there's maybe much
Yeah.
more than just an angle class one. And
Yes. Yes.
just recently, I said to my friend Christian, we're doing a lot of research on this space and teaching now in the US in 2 weeks as well. Um, the guideline to be accepted as a member in the Angle Society or the World Lingo
Mhm.
Society. We met last time in Barcelona at the World Lingo Society meeting. To be accepted as a member, you need to present an extraction case. This
Right.
alone is
Right.
insane for me. So, in order to be judged as a good orthodontist, you
Yeah.
need to
Yeah.
show that you can extract teeth and move the teeth in a static angle class one. Function
Right. Right. Yeah.
does
Yeah.
it's
Yeah.
just our whole system, our whole how we judge a case should be questioned. And I know it's
Yeah.
very controversial what I'm saying now, but that's my strong belief. We need to have different guidelines now.
Yeah.
How we
Yes.
assess what
Yeah.
is a good orthodontist.
Yeah. Well, remember when I trained in London, the saying was you put your plaster on the table. So they measured the intercanine distance. That was a big thing. That it was literally all this sort of stuff. Your cephalometric, A and B, all the traditional stuff. Nothing about does the face look better? Does the is anyone measuring the volumetric change of the airway? Whether you do it radiographically, whether you do it via sleep study, whether you do it by comparing before and after pediatric sleep questionnaires. No, nothing, nothing. So I agree with you. I agree. We almost need to form a new society, don't we? You did a master's in lingual, I'm sure. I remember,
I did,
right? Yeah, with Dr. Filion. Uh,
Fios, Guzzo, all of them.
yeah, yeah, yeah. So. So, we almost need to form our own international orthodontic association for airway, growth guided. We'll call it what you are. Specialists. I think we have to be specialists. And there's more and more. I mean, I travel a lot and I meet a lot of specialists. And I love teaching because if I can change or make that light bulb go off in one person, that means that all those kids they're going to see are going to get a better quality result.
And
How good is that? There's no greater gift in the world than being able look, I love to be challenged. If someone wants to have a debate with me, bring it on. I know my research. Many researchers hardly treat patients. I have a big empire. We are treating 7,000 new patients a year. No one in the world does that. So with that experience and with all that data, I know what I'm talking about, right? And I don't need the extra work. This is not like me putting my cards close to my chest and not wanting to share. Like you want to share. You have a passion for it. If we were business people, we wouldn't share. This would be a unique thing we want to hide, right? So that we can do better.
but our
Uh,
mission is our like this is exactly what I say is I realized I help my own community. I'm growing as a business, perfect, very well. But the
yeah,
bigger picture is in order because I have patients from Hong Kong, from all over the world flying to
yeah,
me. I said it cannot be that parents need to take time off work to fly to me, travel to me hours for their child.
mhm,
It needs to be that there is a local orthodontist who sees the problem, same as you do. So our my priority needs to be the teaching, because
yeah,
that way we can help more children and they get the help they deserve. But
yeah,
the problem really I had is orthodontists are not coming. They don't want
yeah,
to be trained. It's a
yeah,
dentist who says, I see the problem. Please help
yeah,
me how to solve it. And
yeah.
this is a worldwide problem. It doesn't matter which
And I
country
think
you're teaching.
your students will probably be dentists who are frustrated in identifying the problem and referring it to those ones who has watch and wait, right?
And
What
he
I
says, oh,
what I
wait.
call, and I won't name the society where you are, but I nickname it the Flat Earth Society, and they specialize in what I call supervised neglect. In other words, they'll get a kid that they'll encourage referrals at 7 because it's sexy to say I see it, but they don't do anything. And they put that kid on recall year after year, right? You know why? Because they don't know what to do until premolars erupt. They don't know what to extract. You know, it's crazy, crazy, right?
But not only
Um,
that, Derek, they also get a certain amount of points. Every year
mhm.
they say wait until they
Yeah.
get the full whack of points when they treat. So
Oh, really?
to get
Wow.
the
Wow.
maximum benefit of the system, you say
Yeah.
every year, okay, I've seen you check, I get the money for the check,
Yeah.
and then
Yeah.
at the end we get the full points for treating it. So it's
Ah,
also
right.
a system-driven approach. Like
Right. Right.
in Austria, every treatment takes 18 months because the system pays for 18 months. It's
I see. Right.
system-driven. So it's
Yeah.
so the
Yeah.
priority is a business. I mean, you have a business, I have a business, we are fine. I know I want to close the cost podcast with the question, what's your favorite wine? Because I know you're a big wine lover, you know? And obviously, you've done well in your career and really appreciate that we are connected in this journey together. But what's your best wine? What wine would you recommend to
I,
me?
I'm
I
a
love that wine.
I'm a winemaker. That's my passion now. As I slowly retire from orthodontics, I think I will still teach until
You have to.
I'm take.
Derek, you
Yeah.
can't leave me alone in this venture with teaching.
But my goal is to make the world's best Pinot Noir. Now, if you want to rate the current world's best Pinot Noir, I still believe Domay Rome Conti, no doubt about that, right? No doubt about that. Uh, their clone, right, is see, there's 2,000 clones of Pinot Noir. Their clone is what's called the 666 clone, a very easy one to remember. So, and their French are very protective of who can grow this. I am lucky in the vineyard I have this clone. So we are growing in cool climate, the same beautiful wine. I'm learning the winemaker's art. And again, uh, the more time you give this wine to mature, the thing. So I haven't quite got there. I think my Pinots are good, but they're not at the level. So if someone was to say to me, "What is your best wine?" If you come for dinner, what wine would you like? No doubt about it. I would like a Burgundian Pinot Noir. But I'm hoping that now with global warming, all those older wineries, they have to think plan B. It's too warm for the Pinot grape. So, in England, all that area south of England, I think you call it home county, Suffolk, or the French, the big wine houses in France are growing champagne there because it's now with the temperature changing. Yeah. So I think, yes, my favorite bottle of wine would be a Burgundian Pinot Noir, particularly DRC. Um, uh, but to me, the best wine in the world is the one you enjoy. That's
What's your
that's it.
dream? What's your dream for the orthodontic community, for the orthodontic future in our profession where we spend a lot of time in educating ourselves. What's your dream in that venture?
In education,
Yes, in it, whatever.
yeah,
Orthodontic, what needs to change? What's your dream, personal dream that you want to see in your lifetime changing?
I want to see an emphasis on airway first, teeth last. That's number one, right? And I say to my colleagues, you've beautifully straightened these teeth, but I can see that child doesn't look healthy. They're not breathing well. So what you've really done is rearranged the deck chairs on the Titanic. And who cares when that kid is. So I think if the emphasis can be on early interceptive, that helps health. And I'm not just talking about airway snoring. I'm talking about all the conditions that affect the brain in development. And we should be reading the research of Dr. Gozal, who is mapping why these children are not doing well. And I mentioned Australia has the highest rate of Ritalin use in the world. The diagnosis of ADHD is done really just by asking a few questions. It's not, no one is forced to do a sleep study. And we know the signs and symptoms of ADHD are very similar to sleep disordered breathing. But we can fix sleep disordered breathing, and if we fix it early, maybe this child won't end up being that. I'm sorry to say it, but the burden on society that is never going to contribute. I mean, what greater calling do we have in the world than fixing a child to be the best they can be in their face, in their breathing, in their sleep, in their education. And the bonus is they have straight teeth. But I would prefer to have no teeth and have a good airway. That's my thoughts.
So our future should be we're meeting up with a glass of nice Pinot Noir,
Yes.
having made a change in this society. I hope we come to that point, Derek. Thank you so much for your time, and I hope our pathway crosses soon because your story is very close to mine, and you have so much experience. You treat so many kids. I'm far away from these numbers, but if people should listen to what we had discussed today, I mean, it's, I think, very important. So thank you so much. Enjoy the rest of your evening now. I have a Sunday in front of me. Thank you so much,
Okay.
Derek, and hope we see you soon.
Thanks for all you do, Stefan. Bye.
Thanks. Bye, Derek. Bye.